Hi, I'm Dr. Joe Lamb. I'm coming to you from the Personalized Lifestyle Medicine Center by Metagenics in Gig Harbor, Washington. I'm an internist with a background in functional medicine, and we have our unique practice here in Gig Harbor, where we are exploring what function means and exploring how to make a difference in people's health. So we've initiated a series of lunch and learns. It had been our intention to kick these off earlier this year, and we kept waiting for COVID to allow us to start going out and about into the community to have lunch with people, and we finally decided that that's not going to take place. So we decided on a series of lunch and learns, which we're doing online on Facebook, to basically let people know about what we do, what functional medicine is, and why you need it, which is actually the topic of our first discussion in this series. We're going to meet every Thursday every third Thursday of the month at 12 noon Pacific Daylight Time, and we're going to discuss different topics. Some of these topics are going to include our discussion today. Next month's topic is going to be an introduction to your genes, epigenetics, and nutrition. We're going to talk about healthy aging in the modern world. We're going to talk about revisioning your story for changing behavior. And then we're going to start diving into kind of deeper topics around the functional medicine matrix, the microbiome, toxicity, and metabolic transformation, how to heal the gut, the power of our food, facilitating women's health, cardiovascular health, blood sugar imbalance. We're going to talk about all these topics over the next year. We are doing at the moment a number of talks in 5-week little seminars. We just kicked off one this morning on women's health. That video's here on Facebook, and there are going to be 4 more following it. And this afternoon, we're kicking off our cardiovascular health and gastrointestinal health. So let's talk about what functional medicine is and why we need it. I think anytime you set out to define what it is that you're doing or what it is that you're talking about, I always think it's good to define what words you're using and what they mean. So the word function is a very interesting word, and I just Googled it just a few minutes ago to see all the definitions of it. And it's interesting because some of them are not what one would immediately think of, or I didn't immediately think of. For example, the first definition listed is professional or official position, i.e. occupation. The second definition is the action for which a person or thing is specifically fitted or used, or for which such a thing exists. So we're talking purpose there. The next one is any of a group of related activities contributing to a larger action. So this is the one that we're going to be talking about in deeper detail. But functions also an official or formal ceremony or social gathering. It's also a mathematical correspondence, an equation that defines a relationship. It's the characteristic behavior of a chemical compound because of a particular side chain on that compound, on that molecule, what would be called the functional group, for example. And it's finally a computer term for a subroutine within a program. A program can have many different functions. But the part of the definition that functional medicine has looked at is any of a group of related actions contributing to a larger action, especially the normal and specific contribution of a bodily part to the economy of a living organism. So, for example, the function of a heart is to pump blood throughout the body. And that's how the term is used in functional medicine. But the term goes back further than that. And actually, the term was used kind of in two different ways prior to the real definition and founding of functional medicine in the late 80s and into the early 90s. In naturopathic medicine, it means much of what we mean today: the function of the body, the physiology, the ability of the body to carry out the tasks that the organism wants to do. And even in traditional medicine, that physiologic approach was there. But in the clinical world, functional was used in a much different fashion. Functional was used to refer almost to a supratentorial focus, to refer to something being non-physiologically based. A perfect example is the distinction between irritable bowel syndrome and inflammatory bowel disease. In inflammatory bowel disease, when you have Crohn's disease or ulcerative colitis, if you do a colonoscopy, taking a look up in the colon with a scope, you see inflammation and redness and ulcerations and pus and bleeding and ugliness that you can see with your eyes. And clearly there was an anatomical finding that was reflected in the disease pathology of the person. But then you had, and you could begin to work on figuring out what caused it. You could, so in the kind of traditional model of naming, blaming, and taming, it became an opportunity, now that you've named it, to find the appropriate treatment for it and tame it with some sort of pharmaceutical. However, when you dealt with something like irritable bowel syndrome, you listened to the kind of collection of symptoms and physical findings, like diarrhea or constipation and what the stools looked like, that a patient may share with you. But then when you went and did a colonoscopy, you didn't find anything wrong. At a macro level, you couldn't find any findings. You couldn't find pathology at a macroscopic level. And so, it was kind of those sorts of conditions suddenly became functional. Maybe it's related to stress, maybe it's related to anxiety, maybe it's related to something going on cognitively, something supratentorial, the tentorium being that fibrous tissue at the base of the brain separating the skull from the brain, and the concept being that this was something that was not a real disease, that this was something that was in the patient's body. But in the 1980s and into the 90s, when, Jeff Bland and his wife, Susan Bland, who were the founders for the Institute of Functional Medicine, and the work that they did with David Jones and Joe Pizzorno and Sidney Baker and the early founders of functional medicine, and all of these early thinkers and people who were bringing their attention to this, they were paying attention to the way the word was being used, like in radiology or in some of the deeper dives. Radiology, talking about functional scanning, the ability to actually see what the body was doing. Like a PET scan is a functional scan. A CAT scan gives you just a snapshot, right? It gives you an anatomical finding. A PET scan, by measuring uptake of glucose, for example, can show you brain activity, can show you function as it takes place. An echocardiogram shows you function. It shows the heart beating and contracting as opposed to a static image. Doing, a treadmill test, a cardiovascular test, exercise stress test, that sort of test gives you a measure of function. What is your capability? And then you can start, as you assess that function, you can start moving towards the definition of, what do you need to do about it? What does that function represent? So interestingly, they chose the word, they knew it had that other connotation, and that other connotation has gone away, both in traditional medicine, really, and in even in traditional clinical medicine. And certainly its use and acceptance has expanded as a definition of medicine. So, what is functional medicine? Is it just another term for integrative medicine? Is it just another term for holistic? Is it just another term for complementary? Is it just another term for alternative? What exactly is it? Well, the early thought leaders, Jeff Bland and his group, they defined functional medicine as having kind of 6 core principles. The concept there being, what exactly is going on? And one of the core principles that was defined is that, number one, an understanding of the biochemical individuality of each human being based on the concepts of genetic environmental uniqueness. And what this really comes down to is the concept that we aren't all the same. And this is really, it goes back to the work of Roger Williams in the 1950s, who started talking about that people seem to have unique needs for nutritional supplements. Linus Pauling really brought this forward in some of the work that he did, for example, with nutrient needs in sickle cell anemia, for example. The different levels of nutrients played a role in the shape and structure of the hemoglobin, the sickled hemoglobin, and kind of the concepts of orthomolecular medicine that we could have a unique need, that one individual may need a lot more of a certain nutrient, like the trace elements are frequently cofactors in how our enzymes work, where they may need a lot more of one of the other minerals. Magnesium, for example, is involved in an incredible number of interactions that take place in the body. B vitamins are intimately involved in a lot of reactions that take place in the body. And the list goes on, but these cofactor needs are partly dependent upon our genetics. It's recently gotten a lot of attention, for example, around a process called methylation, or the MTHFR gene, which stands for 5,10-methylene tetrahydrofolate reductase, one specific gene that plays a role in the transformation of the folate, kind of the chemical structure of folate, to the more naturally occurring active form of folate. And if you do that well, then you're able to do that one carbon metabolism that we call methylation. If you don't do it well, if your enzyme doesn't work as effectively as it possibly could, then you need to help it by providing either more of the precursor or providing more of the cofactors or some of the activators that turn it on. And those sorts of genetic uniquenesses we can carry with us. But then we also have the environmental component, because, clearly if you have a variant, and these variants, at the most simple of levels, one form of variant is what's called a single nucleotide polymorphism, or a SNP. And what that refers to is a simple little misspelling in the DNA code. As many of you know, that there are 4 nucleotides or 4 building blocks of DNA. And it's depending on the order of these nucleotides that you get the reading of the code and the selection of the amino acid, which is they make up a structural protein or an enzyme. And it's much like a letter in the alphabet. It's much like thinking about a 4-letter alphabet, and all the words are 3 letters long, and they connote meaning, and they call for amino acids, and the amino acids are then strung together, and those amino acids all have different shapes, and when they're put together, you end up having an enzyme or a protein that would have a function. I don't know how many of you played with Thomas the Tank Engines with your kids or yourself as a child, or played with Lionel trains going back further, or put together Hot Wheel tracks or whatever it may be. But that experience of trying to put together pieces and trying to make it so you had a full loop or a more complex structure and have all the pieces come together at the end. Well, if you misread the instructions and put in a right turn instead of a left turn, then you ended up with a setting in which the track wouldn't come together at the end, and you didn't have a complete loop. You couldn't run it all the way around, or there'd be this tight little junction where they hit and the train would derail there, or the car would flip out there in an accident every time. Similarly, when we put together our amino acids, they do the same thing, because the structure of the amino acid leads to its ability to have a function. If it's an enzyme, it needs to be able to grab a hold of whatever it's going to activate. Like if it's like grab a protein and break it in half, it needs to have a pocket that you can do that well. So you can imagine that if you have a pocket that looks something like this, that would be a nice pocket for a protein to fit in. And these right-angled turns are going to be very important for the shape of this pocket. If one of these changed in some dramatic fashion, or even, for example, if the one that called for being straight right here where my thumbs come together, if that changed, you could end up with a much different shaped pocket. If this was a right-angled turn, you'd end up with something like this, and there wouldn't be any pocket at all. Nothing could reach in. If it was a little narrower, or if one of these was, instead of a right-angled turn that went up, went like this, again, you're not going to have much of a pocket to catch anything in. So little changes connote differences. And so, you get a little bit of a misspelling in the 3-letter code or the 3-letter word that's strung together in a paragraph to build a protein. And, when you think about it, dig, D-I-G, and Doug, D-U-G, almost have the same meaning. It's a little bit of a spelling difference, but it does refer to the same basic function and process of, taking a shovel and digging a hole, or a dog digging a hole. But suddenly, if you spell it a little bit different and you get D-O-G, you've got a dog. And, and in the sentence of I dig it or I dug it, you get a sense about what took place. But I dog it, less knowledge, but it's still a word that has some meaning. And then finally, you get to complete misspellings like A, E, or Y. And again, you suddenly are like, they connote no sense. So in kind of our ability, we can carry these small little misspellings. And, what's interesting is prior to the Human Genome Project, the belief basically was that there was not a lot of variation in our genes. There were like a dominant and a recessive gene and that where we saw all the differences in a human being came from having lots and lots of different genes. You know, it's always interesting to me when I sit down in a lecture hall to lecture a group of physicians, one of the things that kind of jumps out at me is that by the end of the day, I can tell where every person in the room, you know, she's been sitting there this morning, he's sitting here, blah, blah, blah. I know who they are. I know who's missing. I can remember who's missing when coming back from a break, even when I didn't know these people. And I can do that because of the variation in how we look. But if I had a room full of human-sized fruit flies, I wouldn't be able to make that distinction as much because fruit flies are very different. And for a long time, we believed that that variation came about from the differences in the number of genes that coded for these structural proteins and the such like. And the Human Genome Project surprised us because it suddenly wasn't just the number of genes, it was the number of variants in that gene that played a role, as well as a number of different factors like the number of regulatory proteins that get turned on and turned off, essentially that decides when that gene should be active. And we'll address that in a lot more detail next month. But the concept here being that, you know, as opposed to there being what back then was called a dominant or recessive gene, so the good or the bad gene, you know, as opposed to that, the concept being that, you know, we had a situation in which, you know, not just one or the other, you had a good one or a bad one, and the function was kind of like a light switch on and off, digital, right? A yes or no response to what was going to take place. We now recognize that these little single nucleotide polymorphisms, of which there can be more than one in a gene, when you put all these together, you have a situation in which the function of that gene is much more analog. It's the turning on and turning off. And it's that kind of, you know, having a different volume, a different level of function that plays a role in our biochemical individuality. So you can have that component. And then there's the environmental uniquenesses, because clearly maybe my, you know, gene has been working well enough. My MTHFR gene has been working well enough when I eat a certain diet. You know, but let's say I get to a certain point in my life and alcohol starts playing more and more of a major role, and I kind of eat the standard, you know, diet associated with kind of the decline. My appetite goes down. I eat less. I'm drinking more. Well, suddenly, and, you know, and it's not unusual to find in alcoholics very low B12 levels and very low folate levels. And then this process isn't going to work so well. There's not going to be enough folate for the MTHFR to work on. And something that maybe wouldn't have been expressed, even though the gene had a little bit less function, only worked at 80% function, when I got enough folate, I was fine. When I developed a uniqueness from the environment in terms of a folate deficiency, suddenly I was challenged. So the first principle of functional medicine is recognizing all the things that contribute to unique needs of each one of us. You know, functional medicine was not the first organization or the first person to think about the fact that people are unique. You know, it goes all the way back to, you know, certainly to William of Osler, who said it's more important to understand the person who has the disease than the disease that the person has. And that's been carried forward. And that really is the second principle of functional medicine, awareness of the evidence that really supports a patient-centered approach rather than a disease-centered approach to treatment. And though William Osler was like one of the people who really defined allopathic medicine and kind of left the voodoo, you know, kind of doctors selling the snake oil medicine by the side of the road, he played an important role in taking medicine out of that and bringing it into an evidence-based world. Well, along the way, even though he recognized the importance of the person in the whole process, that got lost a little bit. And perhaps people ascribe all sorts of less than nice reasons why it got lost. And certainly the pharmaceutical model seems to have led to that. But it was more, to be generous, I think it was more to do with what problems were we trying to solve. At the late 1800s, early 1900s, into right up through World War II, the problems that people were trying to solve were infectious disease. These were the primary problems that led to challenges of health, infectious diseases. So an organism that has invaded another organism has taken over some of the process, has disrupted the physiology that's there, and that organism needs to be gotten rid of. And so there it became very important to name the bug. And once you named it and recognized that, staph is causing the infection in this wound, and it's the infection in this wound that's going to kill someone because they've gotten, a wound on a battlefield, or because it's postpartum sepsis, or because you've just cut yourself shaving, whatever it may be, or you have a pneumonia, or you have tuberculosis, or you have, cholera, whatever it was, a bacteria has disrupted the normal functioning of your body. So if we name it, we can blame it, and there's a drug to tame it. That model works really well for invaders. But as we've seen, because it worked so well, it became the way we approach things. And, it started being, the way we approach things like heart disease. And suddenly everybody and their brother is on a statin-containing drug in order to lower cholesterol, when maybe the process isn't just about cholesterol, but cholesterol was what we would call a druggable target. We knew cholesterol played a role in the onset of heart disease, and it does, but we've also learned a lot about inflammation along the way, and that interaction between the two, and the interaction with lifestyle and the such. But we knew that we could affect the body's production of cholesterol by affecting a certain enzyme called HMG-CoA reductase. And it became what's called a druggable target, because we could probably find a compound that would change that function and would lower a cholesterol level. So heart disease got reduced to hypercholesterolemia as one of the risk factors. Admittedly, we also work on diabetes, and we work on the other traditional risk factors like smoking and hypertension. But one part of it became, here's a druggable target. We can take it, we can work on it, and we can make a difference. And so we had a disease-centered approach, as opposed to understanding, why does this person have a high cholesterol? How's their lifestyle playing a role? The third principle of functional medicine is kind of search for that dynamic balance between the internal and the external. The recognition of kind of the internal homeostasis and what drives it, and the fact that it's really not just a homeostatic process, but it'd be much more thoughtful to think about it as a homeodynamic process. So let's define those words for just a moment. Homeostatic is the concept that the body tries to preserve certain parameters as optimal, right? So, when it comes to the pH of the blood, the acid-base status of the blood, there's a very narrow window of blood pH, and 7.4 is preferred. And if you get much away from that, the body's physiology start changing. In terms of oxygen saturation in the tissues, also a very narrow window. But when you start thinking about something like blood pressure, well, there's not so much. When you start thinking about blood pressure, there is not so much that is a desire to remain static in terms of blood pressure. We used to call 120/80 normal, and now we call 110/70 normal. And But we don't want to be 110/70 all the time. If I'm about to go out and exercise, I want to have a blood pressure that responds by being able to increase blood flow to those muscles that are exercising. And the normal response with exercise is, for example, to see the blood pressure go up, to see the top number, the systolic number go up, and the diastolic, interestingly enough, goes down a little bit, and you get this difference is called the pulse pressure, and you get a widening of the pulse pressure. That's the normal response to exercise. It's the normal response to a fight and flight response. And so it helps us have the function that we want. It helps us be able to exercise. It helps us to be able to run away from the saber-toothed tiger that just jumped into our cave over the fire. It helps us fight, helps us run, it helps us do the things that we want to do. And so a blood pressure being up and having that response, great, but you want it to come back down. And that's the balance internally of the autonomic nervous system between sympathetic and parasympathetic. And it's our response to the outside environment, kind of the external world, moderated. So you wouldn't want that blood pressure to change. You'd want it to be responsive. And so you end up with the concept of allostasis, the ability to change a variable for the benefit of the body. But there's something called allostatic load, which is that there may also be a downside to that. So, when you're pumping more blood, you're putting it through the vessel with more force, and you've got the potential for creating little tears in those vessels, particularly if those vessels don't dilate, if they don't open. It's kind of like the hose on a car. When you get the new car, the hose is soft and pliable and in great shape, but you pump more and more through it over time, and particularly that hot coolant fluid, you get over time stiffness in the hose. And you can imagine that if you get your blood pressure high, it's going to cause little tears in the vessel. So there's a consequence of holding these variables away, and that's what allostatic load is. And given that the average North American has about 50 fight versus flight responses a day, and we'll talk about this when we discuss stress, we're holding this parameter a lot of the time high and suffering a consequence for it. And eventually it manifests itself as hypertension and a disease state. So it's, identifying what is optimal function, how to preserve responsiveness, but not allowing ourselves to get to the point of having an allostatic load, but taking it a little bit further, that our function should lead us towards optimal function, to being able to lead us to move towards being an organism that can achieve our goals. And that's where the influence of the interconnectedness of the mind, the body, and the spirit come together. That kind of deep desire within ourselves, that archetypal, that Jungian drive to something more. So, that's the third principle. The fourth principle is the interconnectedness of the internal physiologic factors. As a natural consequence of naming, blaming, and taming, it kind of leads to a reductionistic point of view. As you're getting more and more information, as you're trying to cope with more and more information, and suddenly there's all of this about the function of the gastrointestinal tract, and cardiology is a whole different area, and neurology and podiatry and psychiatry and surgery. You end up with all these different doctors all taking part of an organism. It's almost like looking at a tree and saying, I'm going to be responsible for that branch right there, and I'm going to make sure that it has green leaves and looks good. Well, if all of us have a different part of the tree in terms of the leaves on the tree, and we all segregate by our professions or our specializations, what did we do in our fellowships? then, or what did we do in our advanced training after medical school, then it becomes this matter a little bit of, we're kind of not paying attention to what's going on elsewhere, or we're not paying attention to what's going on in the trunk or in the roots. And, a lot of traditional medical treatments and a lot of what can be even called green pharmacy these days, where people are simply substituting a botanical or nutritional for a pharmaceutical, but they're still using the same diagnostic model. The concept here is that we should be looking at it a little bit differently, that we should be starting to say, I can't just spray paint my leaves or glue them back on with crazy glue. I need to think about what's happening in the trunk, what those processes are. Is it digestion and absorption? Is it metabolic transformation? Is it message signaling, like through hormones? Or is it the communication of it being carried through the blood? Or is it neurologic function? Or is it, how we build energy? All of these various components are at the center. Is it the interaction that's kind of hard to define, but we have, through our ability as humans to be introspective, has some concept about the distinction between mind and spirit and soul and how that plays a role. And, and that really leads into the fifth kind of core principle, which is the identification of health as a positive vitality. So recognizing that health is more than the simple absence of disease, and that, we can actually be on a journey through illness and disease to optimal wellness, and that should be one of our goals, that we should be aiming towards having wellness and function that allows us to achieve our heart's purpose. And then finally, kind of highlighting the work of DeVries, James DeVries, who talked about organ reserve and the fact that perhaps, instead of having an aging process that starts when we're 18 and we have this slow, gradual decline over time with ever increasing symptoms as we lose function, that if we take care of ourselves, over time, and preserve that organ reserve through a healthy lifestyle, through the appropriate nutrition, through addressing chronic disease, that we can get to a point where maybe we rectangularize that morbidity curve, so we, make it square, and for a lot longer of our life, we maintain good function before there's a rapid decline at the end. And, it allows us to start saying, as DeVries said in a New England Journal of Medicine article in 1980, it allows us to start talking about where we go from here. How do we make a difference? When he put that article out in 1980, people really looked at him and said, nice idea, but it's probably not borne out. But actually, Vita from his lab in 1998 had the results of a prospective study that they did that demonstrated when you preserved organ function, you reduced symptomatology and you created healthy aging. And, this would lead to a change in how people started thinking about medicine and what medicine could be. It led, into functional medicine. It led into an expanded interest by the public in complementary and alternative medicine. It led to changes, but, there was a paper by Crimmins in 2006 that I actually think the paper came out in 2008, and that looking at 2000 data from 1996 to 2006 that talked about this premise and said that unfortunately, modern medicine hadn't fulfilled it, that we weren't increasing organ reserves, that we were increasing length of life, but that increased life was marked by increased morbidity. So, one of the other big, well-recognized movements in kind of movements in modern medicine or modern good medicine is what's called 4P medicine, kind of popularized by Lee Hood at the Institute for Systems Biology, with the concept being, that medicine should be predictive, it should be preventative, it should be personalized, and it should be participatory. So let's touch upon these quickly. Predictive means the ability of what we do to give us something about prognosis for an individual. Like, one of the big reasons for doing a stress test when someone's having chest pain is not just to make the diagnosis of heart disease, but to see what the prognosis is for where they're going. Are they going to have a heart attack? Are they going to have sudden death? Is this going to occur during the next 6 months? Or is it a situation in which there's some stability in what's going on? Part of the, when we start talking about, one of the things that functional medicine does is it uses the current testing that's available and a lot of advanced testing that's available, and like the advanced cardiovascular profile, to look beyond just the standard lipid profile, to look at inflammatory markers and advanced lipid markers, and to get a better idea, of course, and how to intervene and how to make a difference. So predictive is the ability to say something about where you're going and can we do something about it. And hence, if you make predictions and you then have validated preventative treatments, you can do a lot for a person. It should be personalized. It should be not about treating 300 people all the same way. It should be about treating you in one way, treating your brother perhaps in a way that's somewhat similar because you share the same genes, but because you've grown up as adults in different environments, it's going to be different. And going further, it's personalized for every individual. And then finally, it's participatory. And really the concept there being that medicine should be, aimed at, allowing people to be involved. I shouldn't tell you what to do. I should give you some advice. I should point you in some direction. I should be like the trusted pilot on a ship who comes on board, like when you've come into a harbor where you've never sailed. I know these waters better because I've, sailed in them a lot. And you're new to these waters. Your ship hasn't been here before, but you're the captain of your ship and you get to make the decisions. So, as we move forward, functional medicine offers a lot of promise. One of the things that we're doing here at Personalized Lifestyle Medicine Center by Metagenics, with Metagenics as our partner, and with people like Jeff Bland and Lyra Heller as our partners, and Jose Ordovez at Boston University, Michael Stone, Deanna Minnick, this whole group of us, Monique Klass, Michelle Leary-Chang, Eric Lundquist, all of us, kind of Alona Larson, all of us are this team that's working to build and go forward with, trying to figure out, what function actually means. Because if we're going to define health as more than the simple absence of disease, then we shouldn't be defining health by disease biomarkers. Like, I shouldn't say, you don't have these symptoms, hence you're well, or you don't have this risk factor, hence you're well. I should be saying, can I measure your function? Can I measure the effectiveness of your function? And so, for example, I can measure an MTHFR gene and see if you have the SNP, but I can also measure a homocysteine and get a sense of how well that MTHFR gene's functioning. I may not get the whole picture by doing a homocysteine, but I get a little bit of a snapshot that tells me more. So, in our work, we're looking at the metabolic functions, we're looking at the physical functions, we're looking at the cognitive functions, we're looking at the emotional functions, and how they all manifest as behaviors. So it's really behaviors, the center column surrounded by these other four columns, because behaviors really are outward expression of function. You know, we've been on this journey for a while now. We've conducted the first phase of an employee health study called Lifehouse to explore this and to see how functional medicine contributes to the development of optimal wellness, and to look at things like how the nutritional physical exam makes that easier, and what things to measure to define these functions. And we're getting ready to take on the next step of kind of our journey moving forward into Lifehouse 2.0, where we're going to invite patients to join us. And we're about, a few months away from this in Aliso Viejo and a little further away from this in Gig Harbor. But we're going to invite patients to join us in the journey of, collecting data, finding ways to better understand function, and moving people towards advanced functionality. So one of the key points of this is we're not specifically concerned with just how one botanical or one nutritional supplement affects people, but it's how the full expression of lifestyle medicine makes a difference. And that's a term that's gotten a lot of attention, personalized lifestyle medicine. And what that really means is that, going back to Osler and Lee Hood, where they practice 4P medicine using the heuristic of functional medicine, heuristic referring to kind of the shortcut that helps you deal with a complexity of data and come out with an understanding that allows you to make a difference. An example of a heuristic is, and sometimes these heuristics are not necessarily well defined. Like a famous heuristic is they asked baseball players how they succeeded in catching the ball, and all these pro baseball players said, well, I catch the ball because I keep my eye on the ball. And they were like, yeah, but that's what the college players and the high school players and little league players tell us too, and they don't catch it nearly as often or as effectively. And they did all this videotaping, filming of these guys running to catch the ball, and then they put it through a computer filter, and they found out that baseball players keep their eyes at the same angle to the ball. So if I've looked up at the ball and I get this angle to the ball when I've looked up, I keep that angle on the ball. If I'm running fast enough that the ball's going up behind me because I'm getting too far forward, I slow down and bring the ball back into my focus. If I'm not running fast enough and the ball's dropping below, I speed up to get the ball back in my focus. By doing that, I make sure that I get under the ball because I've maintained that same focus. And when I put my hands up, the ball's going to be there. And so that's a heuristic, and it was an unspoken one. In functional medicine, all the thought that's gone in by the people who've contributed has been really about developing a heuristic that allows us to assist people in both dealing with chronic disease and dealing with, kind of the path to optimal wellness. And, one of the things I want to say is that this really is about the kind of the function of lifestyle, because our food inputs are one of the biggest influences upon our body that we can have. Our cognitive behavioral approach, so how we respond to the stresses in our lives, exercise, how we keep a certain function going. For example, as interesting as, and as kind of disconnected as this sounds, the physical activity sensed by the osteocytes in your bone. So, you go out, you walk a long distance, you maybe get little micro fractures from having done the walk, your bone senses it, it releases osteocalcin. osteocalcin actually can send a message back to the pancreas that changes our blood sugar metabolism, saying, hey, we're active, we're out, we're about. And for our hunter-gatherer ancestors, that would have meant it was springtime, it was summertime, we were looking for food, and it would have meant a message that said it's okay to burn more energy. And osteocalcin thus affects blood sugar metabolism to keep us in the right place. It's this interconnectedness. And so, clearly, lifestyle has an incredible amount to do. There are a lot of practitioners who don't really pay enough attention to that in two ways. Number one is a lot of doctors are like, well, I don't really address my patients' needs with dietary approaches. Well, it's not that they're not addressing their needs, they're ignoring an important variable, as Jeff Bland has said, because your patient is eating something. It has an influence. If you're not paying attention, you're not just missing an opportunity for therapy, you're missing an opportunity to take away something that may be negatively impacting what's going on. As Matt Tripp has said, who is the VP at Metagenics here in the past, we're in the midst of this largest health experiment that's ever taken place, the westernization of the diet and what it's doing to us. And clearly we saw during a study in which we took diabetics and we attempted to modify their lifestyle just by giving them a shake, having them keep their diet constant and asking them to add in a healthy shake twice a day and not make dietary changes. It didn't do as much as we expected. And part of that reason was people, even though they should have been more sated because they were getting a good protein and good fiber, they continued to eat all the bad things that they had been eating anyway, and their caloric intakes just went up. And the increased caloric intake and the continued improper diet overwhelmed the benefit from the supplements we were giving them. So that brings up the really, really important piece of behavioral change and how to facilitate people in behavioral change. And we're going to be touching back to that in one of our upcoming lectures. But Michael Stone and myself and the other members of a loosely formed group called the Consilience Partnership, Deanna Minnick, Monique Klass, Michael, and myself, we're working on a teaching program which we had hoped to debut at Feathered Pipe Ranch in Helena, Montana this year in June, and it didn't happen because of COVID. We'll be there next July. We have a nice July date for our functional medicine journey, a 5-day quest towards optimal wellness, and we hope you'll join us there, and we'll be discussing more of that to come. But, I've talked a lot about lifestyle medicine. I've talked a lot about improving wellness, but I just want to really point out that functional medicine is also a tool for understanding all of those rather complex and difficult decisions and conditions that impact people's lives in a negative fashion. We look at and we use all of those principles of functional medicine to try to understand diverse conditions like chronic fatigue syndrome, autoimmune conditions, chronic Lyme disease, possible mold overgrowths, inflammatory bowel disease, cardiovascular disease, diabetes, obesity, just the kind of general lack of wellness. Because one of the things that's very clear is, though, for an acute disease like an infection that someone may have, while an approach of naming, blaming, and taming it with a pharmaceutical may work, our modern medicine environment has been thrown asunder by trying to take that approach and treating chronic disease. So we'll be addressing these issues in upcoming lectures. I've chatted with you for about 55 minutes, and I hope you've had a nice lunch. And we'll be back with the next topic in this series, which again is an introduction to your genes, epigenetics, and nutrition. on the third Thursday in September. So thank you all, and be well today, and go out and let someone know that you appreciate them. Thanks a lot. Bye-bye.